Dear colleagues, today I would like to bring to your attention the case of triventricular hydrocephalus, a rare malformation of the central nervous system characterized by an abnormal dilation of the cerebral ventricles and caused by impaired circulation of cerebrospinal fluid. From an epidemiological point of view, the incidence of this condition is estimated to be between 0.5 and 3 cases per 1,000 births, and there may be a slight prevalence in females. Based on the underlying causes, fetal hydrocephalus is classified as either obstructive or non-obstructive. In the case of obstructive pathology, the most frequent causes are stenosis of the aqueduct of Sylvius or an obstruction of the foramina of the fourth ventricle, as well as Chiari malformation. When, on the other hand, hydrocephalus is of the non-obstructive type, it is associated either with excessive production of cerebrospinal fluid or with its reduced absorption. Fetal hydrocephalus can also be associated with other types of pathological conditions, such as congenital infections like cytomegalovirus or toxoplasma, or it may be the consequence of fetal cerebral hemorrhages or neural tube defects, such as spina bifida. Or it can also be associated with certain chromosomal abnormalities, such as trisomies 13, 18, and 21. But fortunately, in the majority of cases, about 70%, it is isolated. Diagnosis is made during prenatal ultrasound from the second trimester onward, as in the case at hand, which concerns a pregnant woman who came in during the 25th week of gestation. In fact, this is an acute onset condition that can appear at any stage of pregnancy. The ultrasound classification is clinically very important, that is the extent of the ventricular dilation. In fact, we refer to mild or borderline hydrocephalus when the ventricles are dilated between 10 and 12 millimeters, moderate when this dilation is between 13 and 15 millimeters, and severe hydrocephalus when the dilation exceeds 15 millimeters. The gold standard, both for accurately confirming the diagnosis and for carefully studying the detailed fetal anatomy, is fetal MRI, which in most cases is combined with the study of the fetal karyotype through amniocentesis, especially to rule out the possibility of a suspected association with other genetic diseases. In fact, the prognosis, in addition to depending on the underlying cause and the severity of the dilation, is also influenced above all by associated anomalies, as well as by how the condition evolves over time. Indeed, fetal hydrocephalus can, in some cases, progress during fetal life. Focusing on the case at hand, the measurement of the right lateral ventricle atrium was found to be 12.7 millimeters, while that of the left lateral ventricle atrium was 14.1 millimeters. Continuing with the study of the remaining anatomy, a normal cerebral falx was observed. The thalami are not fused together and the cavum septi pellucidi was detected, as well as the measurement of the cisterna magna, which was within normal limits, that is 4.3 millimeters. Following this, we systematically ruled out the presence of any tumors or masses within the cranial fossae that could potentially lead to the development of obstructive hydrocephalus. In cases like this of fetal hydrocephalus, in addition to visualizing the cavum septi pellucidi and the corpus callosum and verifying that it has normal biometry, it is also essential to study the brain convolutions. In our case, the insula is visualized and appears normal. On the other hand, the parieto-occipital sulcus appears to be smaller than expected for the gestational age. It is equally important to verify that the spine is normal, precisely because, as mentioned, hydrocephalus can be associated with neural tube defects such as spina bifida. In this case, spina bifida has been ruled out since the spine appears normal. The blood flow velocity in the middle cerebral artery was also measured, since an increase in this velocity is associated with the presence of congenital infections, such as the previously mentioned cytomegalovirus and toxoplasma infections, or other types of infections like parvovirus B19 or Coxsackie virus. In our case, the blood flow velocity in the middle cerebral artery is 20 centimeters per second. In this case, the remaining fetal anatomy that could be explored by ultrasound at this stage was found to be normal, as was the fetal biometry, which was appropriate for the gestational age, with the only finding being an abdominal circumference at the 25th percentile. In conclusion, and during counseling with the couple regarding the extent of the ultrasound findings, it is necessary to recommend a fetal MRI, which, as already mentioned, is essential both to confirm the diagnosis and to study the anatomy. A study of the fetal karyotype, with particular attention to lissencephaly, given in our case the finding of a smaller parieto-occipital fissure, a genetic consultation along with a neurosurgical consultation, and evaluation for the torch complex, parvovirus B19, and Coxsackie virus due to the aforementioned association with intrauterine infections, periodic ultrasound checks every 2 to 3 weeks, and a neonatology consultation, given the importance of delivering in a facility with a neonatal intensive care unit.